Hi guys, this is Valerie, and in this video I will talk about my fieldwork and how it relates to my research paper. I had the opportunity to complete my fieldwork at Rosh Maternal and Fetal Medicine in one of their Manhattan offices under the supervision of a registered dietitian. So in this slide I just wanted to include the services that the practice provides. Um, They are known for, they provide obstetric and gynecological care. However, they are known for their expertise in high risk obstetrics, maternal fetal medicine, and ultrasound. So, as highlighted in this slide, I really had what I was really part of and was able to observe was the high risk pregnancy population. Now, what exactly is a high risk pregnancy? So, a high risk pregnancy means that the patient and her baby has a higher chance of complications during pregnancy or labor or even after delivery. So, this patient may have a chronic health condition that affects the health of her baby or a health concern that may actually arise for the first time during pregnancy. So, one of the conditions that we're most familiar with is actually gestational diabetes, which is what I was involved with the most during my fieldwork. So I just wanted to bullet some of the various health conditions that cause a pregnancy to be considered high risk. So some of these include mothers aged 35 or older, carrying multiple births, baby has birth defects, prior low birth weight of a baby or early delivery, and most importantly, underlying medical conditions such as diabetes, thyroid issues, or kidney disease. Diabetes being, again, as I mentioned, something that I really was exposed to the most. So, what exactly is the registered dietitian role in this setting, or more specifically, the RD that I worked with was Dina D'Alessandro. So, her mission was, and her goal at Rosh Maternal was very clear, and that was to use medical nutrition therapy to achieve and maintain normal blood glucose in patients who have been diagnosed with gestational diabetes. Furthermore, she also wants to make sure that patients have sufficient nutrient intake for fetal growth and advises on modest energy restriction to slow weight gain in women with gestational diabetes who are also overweight or obese using MNT. So I just wanted to include some examples of a nutrition assessment that Dina makes the patients complete while they're in the waiting room, waiting for her as she assesses each and every case. And what these questions really allow is to kind of create jumping off points for initial consultation so she can guide the conversation in appropriate ways. So, some MNT that I observed for gestational diabetes at Rosh Maternal included caloric intake for overweight or obese women with gestational diabetes, carbohydrate intake, protein and fat intake, as well as physical activity. So some of these we've seen before and we're more familiar with, but as far as caloric intake goes, weight loss is never recommended for pregnant women. However, if a woman was found to be overweight or obese, there is a modest caloric restriction, so about 70% of the DRI for pregnant women is encouraged. As far as carbohydrate intake goes, all pregnant women should receive about 175 grams of carbohydrate to ensure provision of glucose to the fetal brain as well as to prevent ketosis. Total carbohydrate intake should be less than or about around 45% of energy to prevent hyperglycemia in women that have been diagnosed with gestational diabetes. And as far as fat and protein goes, the recommendations are similar to the DRI for all pregnant women. And physical activity, unless otherwise prohibited by the doctor, there is a push for about 30 minutes of exercise per day, at least 3 times a week. And again, I just wanted to include some of the visuals that we show and go over with patients during consultation. So starting on the right, we really implement nutrition label facts and how to read nutrition labels, especially for those women who have been diagnosed with gestational diabetes and are participating in carbohydrate counting. On the lower right corner, we also talk about portion control and portion sizes. So this is a good visual that we show our clients frequently. In the middle, we just have examples of low, medium, and high glycemic index. It's just a good way to kind of go over what foods women with gestational diabetes should eat less of or avoid. And finally, finishing on the left, we always go over, checklists of foods to avoid during pregnancy, because we really want to prevent any foodborne illnesses in a pregnant population, because they're incredibly susceptible. So I just wanted to go over some specific tasks and responsibilities that I personally had with my time at Rosh Maternal. The first one being, I participated in prenatal counseling. I sat in on most of the consultations with the RD, and I participated in patient charting using electronic nutrition care process terminology. I also implemented ADIME in all consultations, and worked on my PES statement skills with Dina after observing each case. Another responsibility I was in charge of was inputting retrospective data over a 6-month period on patients who have already given birth. And lastly, towards the end of the fieldwork, I facilitated in a gestational diabetes frequently asked questions Excel spreadsheet using evidence-based practice, comparing recommendations from ACOG, AMD, ADA, Jocelyn, and published journal articles. So this is, the data that I was inputting look like day to day. Just to give a rundown of the acronyms that we have body mass index, current body weight, pre-pregnancy weight, birth delivery weight, and post-delivery weight. Now, what does this data mean? So after I inputted the data, the registered dietitian Dina accounted for as many confounders as she possibly could. For example, from January to June 2017, there was less patients total than from July to December. And also there was less patients diagnosed with gestational diabetes compared to from January to June compared to July to December. But Dina said that she did account for those differences, so this data is as accurate as she could have made it. But what's really important to notice is that there was a decrease in the amount of women that gained excess weight from July to December, which is when Dina was the registered dietitian for the whole 6-month period, whereas from January to June, she came in towards the end of June. So she really just wanted to see whether her medical nutrition therapy was beneficial to women that were diagnosed with gestational diabetes. Now, it's important to note it, to really take into account, is that Dina didn't necessarily look into the BMIs, in terms of she wasn't trying to get someone who's in the overweight category into the normal category, or obese 1 into overweight. It was really about gestational weight gain throughout the pregnancy that was more of a concern for her. And just to give you an example to put things into perspective, if a patient who was 5'4" starts at 200 pounds, she's 34.3 BMI, obese class 1. But if the patient reduces weight to 180 pounds pre-pregnancy, she's 30.9 BMI. So she's still in the obese 1 category, but she lost 20 pounds, which should account for something. And that's what Dina was interested in. And as you can see, the numbers are kind of clear that if looking at let's say of someone who was overweight, she did decrease from 79% to roughly 3%. The only thing that we were still kind of wrapping our heads around was why the birth delivery weight went up by 2%. But again, there was a number of confounders. This is still raw data, but as far as evaluation and monitoring of your own practice, I think this is a useful tool to use just to see whether your intervention is working, and if not, what can you do to let's say get those numbers to decrease. And again, as I said about BMI, this I pulled from an actual patient. So I just wanted to show that although from August to March during the pregnancy, the woman went from 182 pounds to 219 pounds, again, her BMI stayed the same, roughly the same. And again, so it's not necessarily BMI that we're looking at, but really this fluctuation in weight gain. And looking at the same patient, if you look at the pregnancy weight calculator, she was at the pregnancy stage was 27 weeks, so she should have been between roughly 188 pounds to 195 pounds. However, at 27 weeks, she was at 215, so she was about 20 pounds higher than the upper bound. And again, as an RD, that is what's concerning, because we really want to either maintain weight, or kind of prevent it from increasing that much. So we do want to keep it in that range using medical nutrition therapy interventions. Now, why do we care about gestational diabetes and weight gain during pregnancy? And that really has to do with fetal macrosomia, which is the most common and significant neonatal complication clearly associated with gestational diabetes. So it is a term used to describe a newborn that is over 4,000 grams, or roughly 8.8 pounds. And I wanted to include some visuals. Again, I pulled this data from real patients. So very often physicians and RDs actually look at estimated fetal weight. Now, at Rosh Maternal, what I was used to is what we want it to be between 5 and 85%. I have looked in other literature, and I did note that anything less than 10% was considered small for gestational age, 10 to the 90th percentile as normal, and anything above a 90th percentile as large for gestational age. But again, in the practice that I was with, they were looking at anywhere between 5 to 85. So on the left, both of these women are at 38 weeks. However, the woman on the left is is 13. The estimated fetal weight is 13%, which is about 5 pounds and 14 ounces. So this woman is okay and everything is going great. However, the woman on the right, again, also 38 weeks, but she's at 89% with her baby being 8 pounds and 6 ounces. Now, she still has a few more weeks to go, so the weight of the baby might increase even more. And again, like I said, that's putting her at risk for fetal macrosomia. Now, what is the pathophysiology of fetal macrosomia? So, when maternal glycemic control is impaired and the maternal serum glucose level is high, the glucose is actually able to pass through the placenta. However, the maternal derived or exogenously administered insulin does not cross the placenta. So, as a result, in the second trimester, the fetal pancreas, which is now capable of secreting insulin, starts to respond to the hyperglycemia and secretes insulin in an autonomous fashion, regardless of glucose stimulation. So, this combination of hyperinsulinemia, insulin being a major anabolic hormone, and hyperglycemia, glucose being a major anabolic fuel, leads to an increase in the fat and protein stores of the fetus, resulting in macrosomia. Now, what are some of the complications associated with fetal macrosomia, and why we try so hard to avoid it is due to these immediate complications, including premature birth. So, due to early induction of labor before 39 weeks of gestation and or premature rupture of membrane, there is a risk of preterm delivery. Although all necessary precautions are undertaken prior to induction of early labor, newborns are still under the risk of complications associated with prematurity, including difficulties in respiration and feeding, infection, jaundice, neonatal intensive care unit admission, and even prenatal death. Other complications include shoulder dystocia and Erb's palsy. So these are one of the most serious complications of vaginal delivery in macrosomic babies. So newborns with a birth weight of 4,500 grams or more carry a 6 times higher risk of birth trauma, and the risk of brachial plexus injury is approximately 20 times higher when the birth weight is above 4,500 grams. Another immediate fetal complication includes hypoglycemia, which is the most common metabolic disorder of the neonate of a gestational diabetes mother. It occurs due to the hyperinsulinemia of the fetus in response to the maternal hyperglycemia in utero. Hypoglycemia can lead to more serious complications like severe central nervous system and cardiopulmonary disturbances. Major long-term consequences include neurological damage resulting in mental retardation, recurrent seizure activity, developmental delay, and personality disorders. Another immediate complication includes neonatal jaundice. Factors which may account for jaundice are prematurity, impaired hepatic conjugation of bilirubin, and increased enterohepatic circulation of bilirubin resulting from poor feeding. In macrosomia, neonates have high oxygen demand, causing increased erythropoiesis and ultimately polycythemia. Therefore, when these cells break down, bilirubin, which is a byproduct of red blood cells, increases, resulting in neonatal jaundice. Additionally, congenital anomalies such as heart defects and neural tube defects, such as spina bifida, are the most common types of birth defects. The high blood sugar level of women with gestational diabetes can damage the developing organs of the fetus, leading to these anomalies. And lastly, cesarean delivery. So it it is recommended that if the weight is at least 5,000 grams in women without diabetes, cesarean delivery may be considered, and if the fetus is at least 4,500 grams in women with diabetes, cesarean is also recommended. However, evidence still suggests that an induced cesarean delivery is not recommended. Unfortunately, though, some women do go into delivery thinking they'll have a vaginal birth, but unfortunately, the weight of the fetus is too large for that, and they do resort to an emergency C-section, which you want to avoid. And I just want to point out this graph that I have about the shoulder dystocia. As you can see, that women with diabetes, there's more incidence of shoulder dystocia in that population compared to women without diabetes. Okay, and I just wanted to mention some later complications associated with fetal macrosomia. That includes childhood obesity and metabolic syndrome. So studies suggest that one of the reasons of childhood obesity is actually gestational diabetes in utero. So I wanted to include some studies that supported this notion. One being that the offspring of Pima Indian women with pre-existing type 2 diabetes and gestational diabetes were larger for gestational age at birth, and after approximately 5 years of age were heavier than the offspring of pre-diabetic or non-diabetic women. Another study, the Exploring Perinatal Outcomes Among Children study, found that exposure to maternal gestational diabetes was associated with a higher BMI, a greater waist circumference, more visceral and subcutaneous adipose tissue, and a more centralized fat distribution pattern in 6 to 13-year-old multi-ethnic youth. And lastly, a study that looked at youth that was exposed to maternal gestational diabetes in utero had an overall higher average BMI growth from 27 months through 13 years of age and a higher BMI growth velocity starting at age 10 to 13. So these findings suggest that the long-term effects of in utero gestational diabetes exposure are not always evident in early childhood, but rather emerge during puberty, which is another sensitive period for the development of obesity. Offspring of diabetic mothers is also susceptible to the onset of metabolic syndrome, such as increased blood pressure, hyperglycemia, obesity, and abnormal cholesterol levels that occur together and increase the risk of heart disease, stroke, and diabetes. So, just some takeaway notes that I wanted to mention is that scientific evidence supports the effectiveness of MNT for gestational diabetes. Research indicates that MNT results in improved maternal and neonatal outcomes, especially when diagnosed and treated early. But most importantly, the RD plays an integral role on the interdisciplinary healthcare team by making the optimal nutrition prescription and developing the nutrition intervention plan for patients undergoing gestational diabetes therapy. Okay, and I just wanted to include these as my last slide. Some of the competencies that I think I've met. Well, thank you so much for listening. Bye.